This is me, day number 1 of medical school. You can see just how happy I was. Next thing you know, they said, hey, pat yourselves on the back because you've arrived, you've made it. So I reached back and I pat myself on the back because I made it. Next thing you know, I was standing in front of hundreds of people. They said, hey, sign this document right here. They gave me this little mini white coat. Do I know what I signed that day? No idea. But I knew I was excited. I was in med school. I had made it. In fact, I stood back. I looked out in the audience. And I saw my mother. I said, Mom, we made it. We made it. What a moment. That's when the hard work really began. In medical school, I had a wonderful opportunity to explore an interest area of mine, an area around the topics of nutrition and obesity, areas where many medical schools don't really focus on, as many of you all know, area where I didn't think I'd be able to explore. I voiced my interest, and I was able to work with mentors from all around the country who taught me a variety of skills and techniques I was able to apply in caring for the patients that I saw. One of the most important things that I learned is that obesity, the disease of obesity, is integrated into every subspecialty of medicine that there is. So if anybody needed to understand the disease, it needed to be us. As I cared for my patients who had obesity, one of the things that I noticed was an incredible amount of frustration to my left and my right. Physicians and patients were incredibly frustrated. Physicians said this, hey, I don't feel that my patient is listening to me, and I don't feel the resources I have are effective in addressing the problems that I see. And the patient said this, hey, I don't feel that my physician is listening to me, and I don't feel that I should go back to that appointment to address weight and health. Attrition rate continued to increase. Much of this stemmed from our very rudimentary, archaic view of the disease of obesity. It's simply this, calories in versus calories out. If I just exercise enough and I don't eat too much, then there's no way I can develop obesity. And if I have obesity, there's no way that I can maintain obesity if I just do the right things. But we have to understand that is far from the truth. The disease of obesity that we understand to this day is a complex, multi-system, chronic disease influenced by a variety of different factors, including genetics and epigenetics, our brain, our behavior, our environment, psychology, and so much more. If anybody needed to understand the complexity of this disease, it needed to be us. Why do you ask that? Why should we understand the complexity of this disease? Because if we don't, what we begin to say in our behaviors tend to be something like this. My patient, the reason you keep gaining weight is because you're not listening to me, blaming. Or, my patient, because you are lazy and non-compliant, I don't even want to address this problem anymore with you. In fact, I'm not even going to bring this topic up anymore. Ambivalence, diabetes, hypertension, asthma. We don't do this with any chronic disease, but why with obesity? When we simplify the disease of obesity, our bias begins to increase. And when it increases, we are putting a barrier in front of our patients that we said we would never put in front of them on day one. One of the things I began to ask was a simple question. How do we maximize care for some of our most vulnerable of patients? So we put our heads together. We thought about it. Our mentors, we came together and we said, hey, we recognize this problem. Our families may not be coming to us. How about we go to them? What would it look like if we came to our families? This birthed one of the first nationwide programs that addressed obesity in the homes of our patients. We created a program called Healthy Homes, Healthy Futures, where our residents were able to go into their homes of their families. Why did they do this? To create an intervention or tailor-make an intervention for our families by going to where they lived. Our residents did an incredible amount of research, background research. They tried to get a better understanding of the homes, the environments, the neighborhoods that our families were living in, what resources were available so that they can direct their families towards those resources. They would work in those settings every day, but never would get outside of those clinical settings or the clinical structure to be able to see what was around them. They used another important tool, this one right here. This tool is simply the windshield survey. The good old windshield survey, literally looking through the windshield of your car and observing the surroundings. What resources are around you? Are there street lights? Are there sidewalks? What do the sidewalks look like? What are things that enhance the health of the community? And what are things that are deterrents to the health of the community? They're both are important. Another thing that residents began to notice was that they were bringing their own baggage into every clinical encounter. For years, as they've been counseling, they recognized that they've been counseling from their own lived personal experiences, their own preconceived notions and their own biases. Subconsciously, when they imagined their homes that their families lived in, when they counseled them, it eerily looked similar to their own. When they would go into the homes of their families, they recognized, for years, I've been counseling to eat around the table. When they would go into their homes of their families, they recognized, for years, I've been counseling to go into the large space in the front and the backyard to be physically active. But what if they walked into their homes and they noticed, I'm in a marginalized setting, an under-resourced setting, but there may not be a table in the home? What about when they walked into these homes and they recognized, they looked outside, there's no huge space in the front and backyard. In fact, the family would say, hey, come with me. Look out that window. There's no way I'm sending my child out there. I feel unsafe. These lessons were transformative. Experiential learning is a tool that transformed how they approach the health and the care of their patients. You see, most medical students, most physicians come from middle to upper income backgrounds. Engaging these topics are challenging. We understand, we've been reading about social determinants of health for years, but when we became engaged with this, it became tangible. When our residents were describing patients who had obesity, they would say, hey, these obese patients. What we began to recognize was we're putting the label of the disease as the patient. The stigma, the faulty understanding of labels that go along with this patient was beginning to exemplify. Things like laziness, unintelligent, poor work ethic. All of these labels we were placing on our patient by simply saying that they were this disease. Let's get one thing straight. A person has obesity, they are not obesity. A person has character, personality, strengths and weaknesses, vision, creativity. To relegate this person to simply a disease is a disservice that we couldn't do. If anybody was going to provide a safe haven for our families, we knew we couldn't turn our backs. There were 3 lessons that we learned that we knew we needed to share. Lesson 1, we needed to ask better questions. When my residents walked into the homes of their families, and they engaged with their families and recognized that all this time they've been counseling from their past experiences, it shattered their preconceived notions. They learned how to stop assuming and ask better questions. We all must stop assuming we understand our neighbors, our families, our clients, and humble ourselves enough to engage. This was going to require a lot of introspection of our own biases, our own stigma, to be able to address these concerns. We must own them because we all have them. And then we must check them at the door with our best attempt before we can engage our families and patients more effectively. Number 2, meet our families where they are. Many of us came into this kind of work to help heal, to help serve, to help connect, even to help fix. We have these grandiose visions and goals for our families, but we must recognize that we have to do the first step, the hard work, in meeting them where they are. Recognizing that their needs, their desires, far outweighs our own. And lastly, number 3, let's focus on their strengths. We all know the importance of recognizing the needs and the challenges that individuals and communities face, and this is really important to understand. But what if we only focus on that? What does that do? It creates this superiority complex. Why do I say that? Well, I have a great mentor of mine. She just turned 80, Ruth Perot. She says something to me. She says, Dr. Kofi, remember this. Never confuse those initials in your title, MD, with medical deity. What do you mean by that? Don't they need me? Ruth reminds me of this. The way this works is to remember that every individual that you serve has talents, gifts, skills, creativity. They have so much more, and the neighborhoods that are in them, that they live in, also they have these things. So as a result, let them be their own change agent for health. What do? We walk alongside of them as we go on this incredible journey together. 21st century clinicians need to know how to take a blood pressure. Very, very important. But more importantly, we need to have a new lens so we can provide the compassion to the patients that they deserve. And that's something all of us can do, whether you have a white coat or not. Thank you.